Hi there, this is Dr. Renzo Cataldo, and I work with Arizona Arrhythmia Consultants in Scottsdale, Arizona. Today I'd like to talk about ablation techniques for atrial fibrillation. Right? I'm going to be using my iPad because it can show off my artistic talents. Well, atrial fibrillation is a condition in which the top chambers of the heart are not in a nice normal rhythm, but they're in sort of a chaotic rhythm. And the atrial fibrillation usually arises from the top left chamber of the heart, whereas normal electrical signals arise from the top right chamber of the heart. Now, in the top left chamber of the heart, there are four veins that transport blood rich in oxygen from the lungs into the top left chamber of the heart. Now, in biological systems like you and I, there's no distinct cutoff between one type of tissue and another type of tissue. And what I'm referring to is that the heart muscle itself is very electrically active, whereas the veins that transport the blood are not electrically active. So at that transition zone between the top left chamber of the heart, which is called the left atrium, and the pulmonary veins, which are the veins that transport the blood from the lungs, that transition zone seems to be very electrically active in certain people. The object of the game in ablation techniques for atrial fibrillation is to create a barrier between those veins themselves and the atrial muscle itself. Now, that barrier is not a physical barrier, but it's an electrical barrier. So here's what we need to do. In order to get to the heart, we have to get there from the creases of our legs. In the creases of our legs, what we're born with are two big blood vessels on each side. One's an artery and one's a vein. We get inside the veins and place some skinny little tubes inside the veins. Through those tubes, we can thread some skinny little wires under some X-ray guidance, but mostly guidance from a system that we call a mapping system, which is a computerized system that helps us visualize the catheters themselves, these wires themselves. Those wires are then passed over to the heart, and those wires kind of park themselves in the top right chamber of the heart because we're going in through veins. What we have to do is to pierce a little membrane that exists between the top right chamber and the top left chamber of the heart. Once we pierce that membrane, we can thread some tubes over the needle, and through those tubes we can thread some skinny little wires over to the left atrium. These two wires are distinct from each other. One is a circular catheter that kind of looks like a cowboy's lasso, and as a matter of fact, one of the manufacturers calls it the lasso catheter. The other catheter is used to map on the inside of the heart and also to deliver electrical energy to create this electrical barrier that we'd like to between the veins and the left atrium. So once we create this electrical barrier between the veins and the left atrium, then any extraneous abnormal heart rhythm that originates from the veins themselves cannot make its way past that barrier. Now, the barrier will eventually be scar tissue, and the scar tissue will take several months for it to be completely formed. We take the tubes out and we take the wires out of the heart. We leave the tubes inside the groins for several hours until the effects of the blood thinners wears off. The procedure itself can be a lengthy procedure. It can be from 3 to 4 hours. And sometimes it doesn't simply involve creating those barriers, but we have to look for other abnormal heart rhythm disturbances in either the top left or the top right chambers of the heart as the patient needs. But these can be lengthy procedures, and as a result of which, the X-ray exposure for these lengthy procedures can be very significant. And X-ray exposure can cause damage to a patient, not just in a one-time deal, but it can be cumulative after multiple X-ray exposures throughout the patient's life. So that's why I tend to use the minimal amount of X-ray possible. I manipulate and maneuver these catheters on the inside of the heart with just a few minutes of X-ray exposure for a lengthy case. My average exposure was about an hour of x-ray to the heart. And now I'm averaging about 5 to 7 minutes. So I really like to expose my patients, myself, and my staff to the least amount of x-ray possible. Thank you for listening.